Hello to everyone. My name is Frederick Giuli. I'm the president of the ESO Foundation. Welcome to this virtual staff meeting organized jointly by ESO and OESO-SEMPIRE.
I'm really grateful to all of you to being there. As you know, this is the first session, the inaugural session of this newly created virtual educational channel of the OESO-SEMPIRE. And today we have the chance to have Professor Luigi Bonavina from Milan and Professor George Triadafilopoulos from Stanford University, who will be managing a patient case, a long history of GERD, association of a giant hiatal hernia. So today we have 150 participants who have registered, a little more than this, represented in 45 countries. People are coming as I'm speaking. A lot of people in Europe, in the US, in Brazil. A few of them in Africa, and as the night will be late already, I thank people in Asia, Southeast Asia, and Australia who are with us today. So thanks to all of you being there. Just a few rules. Please switch your cameras on if you're comfortable with this, so we can see you, but keep your microphone muted. You are muted by default, but keep them muted. That's important to avoid background noises. Now, if you want to intervene during the session, you will have two ways. The first way is during the chat, and the second way is using a button to raise your hand. So how do you do this? This is a screenshot of what you should have at the bottom of the screen. It might depend on which kind of computer you're using, but basically these are the buttons you need to identify. The first one is mute and mute. The second is switching your camera on and off. The third one is to raise your hand. You click on participant and you'll have a button here, raise your hand. When you raise your hand, as the administrator, I will see your hand and I will be able to allow you to talk when it will be a good time for it. And the last point is the chat room, where you don't hesitate at any time to put a comment, to put a question, and we'll go from time to this chat room to take your questions and comments. All right. So this is the agenda for today. We'll have a short introduction from Robert Giuli, then a presentation of the case with Luigi Bonavina and George Triadafilopoulos. We'll have a panel discussion. At this point in time, you can shoot your comments and questions to the chat room, and then eventually we'll open it to the floor. So you can raise your hand and we'll take question one by one. So at this point, don't hesitate to raise your hand. So I will hand it over to Robert. Robert is the founder of ESO. He's the Deputy Executive Director. He's also the Director of the Executive Committee of the ESO Foundation. Robert, I hand you.
Thank you, Frederick. A few words for introduction, just to let you know the panorama of what we are doing now. Every one of us know that it is here now, COVID-19, and everywhere meeting and conferences are cancelled. ESO is attentive to the concern of its members who share its mission of spreading information and disseminating knowledge in all disciplines related to the foregut. That is why, under the present circumstances, ESO has decided to launch a new initiative, which, like many of the previous ones, will be original, multidisciplinary, and from the outset, global. This project, la première slide, s'il te plaît, is built on the strong structure of the platform. La première slide, Frédéric, s'il te plaît. Merci. The platform of excellence in esophagology, organized with the SEMPIRE, which is the Stanford Esophageal Multidisciplinary Program, Innovative Research Excellence. La suivante. 11 pilots, la suivante. 11 pilot centers of excellence in esophagology represent the core of this platform. These pilot centers are located, as you may see, in the 5 parts of the world. They propose educational programs for trainees, for fellows, and even for heads of departments. But as you know, these programs had to be temporarily suspended. Reason is the current crisis and tragedy. Today, therefore, we announce the SEMPIRE new global initiative of the virtual channel. Today is our first virtual interactive discussion on a challenging clinical case proposed by one of the pilot centers. Today, the pilot center in Milan, led and headed by Luigi Bonavina, an old friend, with the commentaries of a world-renowned expert, today, George Triadopoulos, Mr. T, President of Honor of ESO. And what is proposed today is a fine example of the multidisciplinarity, which has been the backbone, really the backbone of ESO in the scientific community since its creation. Indeed, the head of the ESO Pilot Center in Milan is Luigi Bonavina, a renowned surgeon. La suivante slide, s'il te plaît. And the regional officer for Europe in the ESO and SEMPIRE advisory board of the platform. As you can see here, this advisory board, presided over by George Triadopoulos, puts together representatives of Africa with Russell White, North America with Larry Miller, South America, Bruno Zilberstein, Asia, G.A., Australia, Matthew Reed, and in Europe, Luigi Bonavina. This is alphabetical order. In Europe, Luigi Bonavina is the regional officer for all the countries of Europe. He be assisted today by 2 young surgeons, Professor Emanuele Asti and Stefano Siponi, who will be there for a part of the presentation of the clinical case. He is heading the center in Milan. Invited discussant is George Triadopoulos. From Stanford, he is a world-renowned gastroenterologist and endoscopist, and at the same time, he is, as you may see, the president of the advisory board of the platform, which is made up of these officers. And the virtual panel for our discussions today will comprise Carmelo Scarpignato. All of you may know him. He's professor of clinical pharmacology and gastroenterology, and he's very attentive of having the term of professor of gastroenterology in addition to his title of professor of pharmacology. Hiroshi Mashimo is a researcher and endoscopist world-renowned at Harvard University, and Denis Collet is a former president of the French Society of Surgery. The coordination of the project and the technical part are taken in charge by Frederick Julie. He's the president of the ESO Foundation, and let me say clearly how proud and pleased I am today to hand over to him the heavy responsibility borne by this position of president of the foundation. 155 people, 45 countries who have registered, they all have registered for this event, which is transmitted worldwide. However, it is accessible at a comfortable time of the day in Europe, in North America, in South America, and in Africa. And to close this introduction, I wish to add something of great importance to me. Among the 155 people today connected to watch the discussion, and also to actively participate in it, are several of those who contributed to build the reputation of ESO in the scientific community. There are many of them connected today. They are still loyal to ESO, and my hearty thanks go to each of them. Thank you. And now let the discussion begin. And I have heard Carmelo Scarpigna say, you cannot help for speaking during my talk. I can hear you, Carmelo, even when you don't speak. Let the discussion begin.
Great, thank you for this introduction, and I hand it over to Luigi for the case presentation.
Thank you, Frederick. Welcome to everybody to this educational web conference. And special thanks to Robert Julie, of course, who is, as everybody knows, tireless Iron Man in pursuing the mission of the OESO. And I think he did spectacular work. And this is one of the initiatives that one of the initiatives was to create this educational web conference, which is intended as a worldwide multidisciplinary staff meeting. Come vado avanti? So this is my staff, Emanuele Asti, Stefano Siboni, and the youngest guy here is Carlo Alberto Manzo, who contributed to this case presentation. And just to show you, we are a high volume esophageal cancer and center also for benign disease. This is our experience over the past years. This will be a highly interactive conference. So as Professor Julie said, and Frederick, please raise your hands for questions. And so I'm going ahead, and the topic for today is what we call a challenge of paraesophageal hernia and the intrathoracic stomach. Just to show you the entity of the problem seen during a laparoscopy, and just saying that this is a very heterogeneous clinical entity that represents up to 15% of all hernias. Type 3 is the most represented. Often those patients are asymptomatic, and we'll see that this is a big issue for discussion today. Most of those patients are elderly females, and we'll see the reasons why. And of course, being elderly and frail, a lot of those patients have multiple comorbidities. The reason why hernia develops is because there is a weakening in the hiatus, and this is a very dynamic area with a lot of interferences by heartbeats, cough, vomit, sneezing, swallow, and breathing activity. This is a special, we'll see also in our patient, a predisposing factor to those huge hernias, which is a kyphosis, and this change in the spinal curvature can be a very important pathogenetic factor. Also, there are some molecular reasons, collagen metabolism alterations, defective elastin in the phrenoesophageal ligament, and also some genetic abnormalities. And this is, more importantly, the natural history of paraesophageal hernia that goes through an organoaxial volvulus to a mesoaxial volvulus with the complications of bleeding, strangulation, and perforation. So at this point, I would like to give the presentation in the hands of Emanuele Asti, who will tell us about the case we discussed today. Please, Emanuele. Emanuele? Emanuele, are you there?
Yes, I'm
Okay,
here.
please.
Thank you very much for the invitation. Just trying to share the PowerPoint. Just a minute. Share.
You can see it now.
Funziona? Okay, the patient that we are speaking is was a 80 years old lady that was an active woman, and she was admitted to our emergency room because she was complaining about postprandial retrosternal pain, inability to vomit and belching, and resting dyspnea. The physical examination of the patient, she was 1.5 meters high, and she had a BMI of about 28, and the blood pressure, heart rate was quite normal, with SpO2 of 84%, and she was also afebrile, and she was also complaining about mild respiratory distress with a very high respiratory rate. And from the physiological point of view, she had a severe kyphoscoliosis. And she was taking at home the sotalol 80 milligrams daily, and irbesartan 150 milligrams daily. And in the recent medical history, she had recurrent episodes of chest postprandial discomfort, with sometimes complaining about regurgitation of food, and sometimes also inability to vomit and belching. In the last few years, these symptoms were worsening day by day, and also she was complaining about fatigue, and blood tests were able to found anemia, and so the general practitioner started some oral intake of iron therapy, and in two times also she needed blood transfusion. In the last few months, she also lost about 10 kilos, and in the past medical history, the patient, as we have seen before, had the hypertension and chronic atrial fibrillation, and also she underwent to an open cholecystectomy when she was 40 years old. And she started also the therapy for the GERD, that was in the first part of this disease well controlled with PPI, and she underwent also an endoscopy in 1998 and was found a grade A esophagitis with just a small hiatal hernia. And after that, the GERD symptoms progressively replaced by postprandial chest discomfort, bloating, and sometimes diarrhea that was not with the particular type of food or something like that. And with dietary adjustments and the regular intake of PPI, this diarrhea was going not so good. So she started taking rifaximin for 1 week per month. She had also, for the particular disease, an Hartmann resection with the reverse colostomy in 2011. So when for this patient we started the first.
Emanuele,
Yes.
can you just stop
Yeah.
for a while? I'd like to ask Professor Triafidopoulos. George, what do you think about this past medical history? We don't want now to discover everything about this patient, but you, of course, you realize which will be the next steps in investigation, etc. But which is your opinion about this past medical history with cholecystectomy, for example, and this patient in whom the symptomatic pattern has changed over the past 2 decades?
Do you mind, Emanuela, do you mind putting the last slide up so I can just take it one at a time? So I can be a little bit more specific. Thank you, Luigi, and thank you to everybody who's participating in this webinar. So as you look here at the past medical history, the hypertension probably is irrelevant, although long-standing hypertension may cause some degree of burden to the heart, leading to early or late congestive heart failure. The second piece, which is the chronic atrial fibrillation, may be related in some cases to the presence of a hiatal hernia or even to the presence of gastroesophageal reflux, because it triggers the nerves that feed the esophagus, and they may cause a triggering of the fibrillation from the heart. So sometimes there is a relationship between the two, and treatment of the reflux with proton pump inhibitors or correction, surgically speaking, of an underlying hiatal hernia may actually improve the fibrillation or other kinds of heart irregularities, such as ectopic primary ventricular contractions or atrial contractions. The second piece, which is the open cholecystectomy at 48 years of age, may also play a role here, because the cholecystectomy leads to a significant degree of bile coming down to the duodenum without storing into the gallbladder, and this may lead to duodenogastric reflux. And as such, it may make a person a little bit more symptomatic from a reflux perspective, because now you have the additional bile that comes up into the stomach and then backwards into the esophagus. More importantly, the cholecystectomy may cause something that's called post-cholecystectomy diarrhea, which is the case in this particular woman who was treated empirically, I presume, with rifaximin. A better approach would have been to use bile acid binders, such as cholestyramine or cholestyramine. The third thing that I wanted to emphasize here is that the endoscopy in 1998, which is about 10 years after the cholecystectomy, showed some grade A esophagitis and a small hiatal hernia. So we have probably here the beginning of something that evolves over time. And obviously, I don't know when this patient presented to the hospital now, but it took several years for it to evolve into something more significant. And you have the progressive development of postprandial chest discomfort, associated bloating, and episodic diarrhea, probably as a reflection of the cholecystectomy. The dietary adjustments play a significant role here, mostly for the post-cholecystectomy diarrhea, but they may also, dietary changes may improve the associated possible duodenogastric reflux. The standard proton pump inhibition dose was instituted probably empirically, and it's possible that it requires some adjustment over time. Finally, I do not know why she had a Hartmann's resection. I imagine she presented with some kind of a diverticular event, diverticulitis, I presume, and required a Hartmann's resection, which was eventually reversed. So we have a few events that took place over the course of the past 20 years that, and I forgot, of course, the issue of the spinal issues with kyphosis that, as Luigi pointed out earlier, may play a role in the induction of the hiatal herniation. Luigi, back to you.
Excellent. I think this is a very nice and complete overview, and I think that it supports the evolution, let's call natural course of the disease over the years. But you clearly explain, I think this was very pertinent, that the cholecystectomy, by changing the pool of biliary acids, etc., could have determined the diarrhea, the bowel symptoms. But well, actually, this lady had was quite unfortunate, and she ended up also with a Hartmann resection. So let's have Emanuele. Can you proceed with your presentation, please? Going
Yeah.
to the first level investigations.
Yes. So because the patient was stable in parameters, so we started the first level investigation, and we started with the ECG that was able to find a non-significant ST segment depression with a T wave that changes that was not atrial fibrillation, was a paroxystic atrial fibrillation. And after that lab tests, we can see just little anemia, HB 8.5, with a normal count of white blood cells, and no enzymatic point that was negative, so no risk of myocardial ischemia. Amylase was regular, and LDH also regular too. So the blood gas was clear that the patient had an alkalosis with lower levels of PO2, and the transthoracic echocardiogram was able to find a concentric hypertrophy of the left chambers of the heart, and with the mild mitral insufficiency. So it's very interesting to see the chest film where we can find air fluid level, and with the no pleural effusion. You can see here in the lower part of the mediastinum and also in the left chest this enlargement with the high fluid level, and the lungs right and the left were absolutely regular. So it was clear that for this patient we have to place a nasogastric tube in order to perform air venting and aspiration of the gastric contents, and so the patient was able to have a prompt symptomatic relief of symptoms. So we have to start also hydration, intravenous hydration with a continuous infusion of PPI. So we have now to start a second level workup in order to define in a better way the disease. So we perform a CT scan and also an upper endoscopy. We can see here the lateral view of the chest, of the X-ray chest, where also the NG tube was placed inside of the gastric of the stomach. You can see here that there is a clear evidence of a volvulus of the stomach here, with also the level of the air fluid level here. And this is also the CT scan before placing the NG tube and before starting the aspiration. You can see here the wide enlargement of the mediastinum due to the stomach. So we start performing the endoscopy that was able to identify a grade B esophagitis with a very large, with a giant hiatus hernia that was larger than 10 centimeters, and were also found some Cameron's ulcers. And we know that the pathogenesis of the Cameron's lesions is nowadays poorly understood. Some attribute lesion formation to mechanical trauma, to the esophagus caused by respiration or related to diaphragmatic contractions, or in other cases, some etiological factors may also include acid reflux, ischemia, HP infection, gastric stasis, or vascular stasis. So it's also important to see that for this patient was found a very important gastric volvulus, and it's also important that with this condition sometimes we can have a vascular compromise because of the volvulus, and so we can also find the gastric mucosal ischemia that may also cause ulceration, bleeding, and later anemia. In this patient, iron deficiency anemia can be seen in up to 50% of patients with these large hiatal hernia. So this patient was also found inability to find the way through the pylorus because of the volvulus. This is a nice video. We can see here the esophagus. It is completely distorted. This is very important esophagitis. It was not so easy to find a way in the stomach. Now we can see here the pillars, some bleed, some ulceration, some also fibrin. And the mucosa was quite regular in the lower part with some erosions. And was the endoscopy. It was a very skilled surgeon, was also a very skilled endoscopist, but as you can see here was very, very difficult. It was impossible to find a way through the pylorus. It was impossible to find an access to pylorus. So you can see that was very important the placement of an NG tube with eye venting and aspiration of all the gastric contents. And after that, it was important to establish what to do with the patient. So in our institution, we started a multidisciplinary and an assessment also with the anesthesiologist in order to understand for all the for the medical equipe what to do for this patient, for a patient like that. So
Emanuele, can I interrupt you for a second?
Yep.
So I can somehow give you my perspective from the gastroenterological perspective on the case. If we can go back to the slide that talks about, the previous one at the beginning of your presentation on the investigations. I would like to make some comments, which I think are significant. If we can go back a few slides. There, that's good. So
okay.
Let's move on to the next. To make a few points here, you do have a significant degree of probability that you will see these non-specific cardiac changes. And it's important for people not to confuse that you have a myocardial infarction sometimes, because you'd see a variety of electrocardiographic changes. In the lab test, the hemoglobin of 8.5 is quite significant and raises the possibility, as you mentioned, of significant degree of Cameron's ulcerations and intermittent, basically strangulation that can cause the changes that you saw by endoscopy. The blood gases suggest the presence of basically alkalosis and hyperventilation with significant compromise in the oxygenation. And that actually is an important piece of information that you will discuss, I presume, with the anesthesiologic assessment. The cardiac ultrasound that showed the concentric hypertrophy is consistent with her long-standing hypertension as opposed to anything else that we see now. The chest film is important, however, because it shows air fluid levels, which are quite impressive on just a plain chest x-ray. What that brings up in the conversation is the introduction of a nasogastric tube. In my opinion, that introduction of the NG tube should be very carefully done, preferably not by a nurse and preferably by a physician. And in my practice, at least, under the circumstances that we have here, I would prefer to do basically what we do in sigmoid volvulus, which is to use the endoscope to go through the volvulus formation and introduce a wire, and then over the wire, a nasogastric drainage to decompress the intrathoracic stomach that we have on this x-ray, which is very impressive and suggests the presence of a stomach, but it's important to ensure that there's no other organ there, such as the small bowel or the colon behind the stomach. Thankfully, your NG tube placement allowed the air venting and aspiration of gastric contents, because that's obviously an important issue in these patients, because you may have basically aspiration before even you put the nasogastric tube, or even in the time that you do an endoscopy. And thankfully, she was promptly relieved by the introduction of the tube, and then allowed you to continue with the appropriate measures. Next slide, please. I wanted to make some more points, and this is, of course, an examination. Before you go that fast, go back a little bit. So next one is an examination by CT scan. That examination is very important, as I mentioned earlier, because it allows you, obviously this is one cut, but it allows you to examine the possibility that this hiatal hernia is not, or it is, associated with other herniation of colon predominantly or small bowel. So that is an important tool. The CT scan is a very important tool because it allows you to assess how many structures have moved up into the chest together with the stomach. Next. So this examination showed, as you pointed out and saw that by endoscopy, shows grade B esophagitis. It assesses the giant hiatal hernia, which you measured at about 10 centimeters. I believe that that assessment is best done by a CT scan or a manometry. When you do an endoscopy, we all know you insufflate air, and that's the advantage of that. The air insufflation allows you to gain access into the hiatal hernia and possibly untwist the hernia, but the measurement of 10 centimeters endoscopically is not accurate because you have insufflated air. More importantly, you showed cavernous ulcerations, which are the explanation for the patient's anemia, and you demonstrated the gastric volvulus and also the difficulty getting into the pylorus. For the endoscopists in the audience, I would suggest if they have difficulties to get into the pylorus is to change the position of the patient. So when you're doing the endoscopy under the standard circumstances, which is a left lateral decubitus position, what you could do is you can switch the patient in one position or another, and that switches the stomach around and allows you to gain access to the pylorus. So is that important? It's not necessarily important. The most significant thing that you accomplish with the endoscopy is to basically, hopefully, rotate the stomach and drain it. And by that drainage alone, you may be able again to access the pylorus. But more importantly, it allows you to assess for the cavernous ulcerations that are important in the creation of the anemia. So these are my comments that I wanted to make before you talk about the anesthesiologist. I think is the next slide.
Yes, thank you very much.
Well, just a second, Emanuele.
Yep.
Let me add something. I love this comment that George made. Let me tell you a very short story. I had a patient a few years ago. She was, I think the same age, was 80, 82 at that time. And she was having repeated episodes of gastric incarceration and an endoscopy. She was from Piedmont. She loved to eat, and she had recurrent episodes, and she had an endoscopist in her area where she lived, was close to Turin. And this endoscopist, as you said, she used to change the position on the bed, and he was able to reduce the herniation doing a kind of inverted alpha maneuver, and the patient was incredibly relieved. She had this procedure probably 20-25 times, until this guy called me and said, Luigi, can you see this lady? Because, you know, I'm doing this. I'm very happy with this procedure I'm doing. But I think that there may be some day that she can get in trouble. And as a matter of fact, I was at a surgical meeting in Rome, and he called me in the evening saying that, well, listen, after 20-30 attempts to do that, I was successful every time, but then she got a perforation, and so I had to operate on this lady on an emergency basis. And I think that you made, this was a great point. The other point is that it's not so easy to insert an NG tube, so we have to be very careful. And probably in the literature, the rate of a successful positioning of an NG tube is around maybe 50%, because it's not always so successful. Good. Do you have any comment on this?
Yeah, I do agree. Actually, probably your gastroenterologist friend had a child in college or something and he needed the money. But you don't do this 20 times because you're taking a risk of perforation, as it happened, I presume. You do that at the acute event, particularly since this lady had this difficulty swallowing, difficulty belching. These are kinds of phenomena that suggest an imminent strangulation of the stomach, which is in the chest. You do that in the acute event. You do it to define the anatomical situation and also to place a decompressive tube, and you do that over a wire that you press endoscopically through the scope, and then over the wire you introduce the NG tube to provide you with a transient relief. I have never heard of the story of doing it 20 times. It's kind of interesting though.
Yeah. And can I ask if Dr. Denise Collette is with us?
Yes, I am with you.
Hello.
Hello.
Do you have any comment on this case?
Yes, I have some comments. Can we go back to some slides, please? No more.
Can you go back, Emanuele? Emanuele? Can you go back? Few slides. Okay.
For example, this one. Two comments. First, about the dyspnea. It is very frequent to see some patients with a very large hiatus hernias with a very severe dyspnea. And usually it is attributed to the lung compression by the volume of the stomach in the thorax. In my experience, we have seen some patients who had not very large hiatus hernia, but very severe dyspnea. And I am sure, and we are studying now in my department, that the dyspnea does not originate in the lung compression, but is a malfunctioning of the diaphragm. And when you are restoring a normal hiatus orifice, you restore probably a normal diaphragmatic functioning with an improvement of the dyspnea. Some comments?
No, that's a very good comment. I also agree with you that not always lung compression is responsible for dyspnea. Actually, we believe, and we did some studies, we'll show you later, that cardiac compression can be responsible for dyspnea and fatigue in some of those patients. We did some cardiovascular magnetic resonance showing that the heart may be, sometimes the role of the heart compression is underestimated, and maybe there is a problem with filling of the right atrial and ventricular cavities that can be responsible for a global cardiac impairment, which is restored after surgery.
And my second comment is the attitude of a surgeon facing such an emergency case. In this situation, in my opinion, the first problem is the viability of the herniated stomach. Is it necrotized or not? And first, you can put an NG tube or a solution to decompress the stomach thanks to an endoscopy or NG tube. But the major advantage for me of the CT scan is to check the quality of the vascularization of the gastric wall. And sometimes you can see that there is necrotizing area with not also very poor vascularization, and sometimes there is some gas in the gastric wall, which is a sign of severe necrotitis. And for me, it is an indication for emergent surgery, even after decompression.
Yeah, very good point. Thank you. And can I take advantage of also Professor Scarpignato should be with us. Do you have any comment, Carmelo, about the previous medical management in this patient? Is Dr. Scarpignato with us?
Can you hear me?
Yes.
Oh, I was saying that I was surprised to see that despite the chronic atrial fibrillation, the patient was not on anticoagulants, be the old one or the new anticoagulants. And second, I feel that the idea of George to look at other portions of the GI tract to see if there is a weakness somewhere is absolutely correct. And indeed, the patient likely had the Hartmann procedure because of an acute diverticulitis, maybe complicated acute diverticulitis. Then the patients should have had diverticula, which were inflamed afterwards. And this is maybe the reason why she was on cyclic rifaximin, which is a very good drug to treat the so-called SUD, symptomatic uncomplicated diverticular disease. These are my two comments on the previous history and on the, let's say, previous pharmacological therapy. In addition, thanks to the cholecystectomy, it's very likely that the patient had also duodenogastric, as George emphasized, reflux, and then often it happens that the duodenogastric reflux becomes duodenogastroesophageal reflux. Did you see any metaplasia of the lower esophagus or not? Because in a long-standing reflux with a likely biliary reflux, I would expect a Barrett, even a short Barrett.
Emanuele, do you have answers for Professor Scarpignato? Very good, pertinent questions.
No, the exposition was very clear, and we, from this room, we have no question, right, Stefano?
No, do you have an answer to the Professor Scarpignato's questions regarding the home therapy? Maybe we miss some anticoagulant, some anti-aggregant drug, I don't know, but she was on chronic fibrillation. That's
Luigi, this can also justify the anemia, because of course a patient who is anticoagulant therapy would bleed more easily compared to one not on anticoagulant therapy.
The patient
also, my question about the bile could be answered by pH impedance, because with pH impedance in a patient having a bile into the esophagus, the reflux is much less acidic and more weakly acidic or even neutral.
So you mean that having duodenogastroesophageal reflux could increase the chance of Barrett's esophagus?
This is well known. I mean,
yeah,
it is not mandatory. It is not mandatory.
Sure.
Yeah.
Well, that's a good point. I don't think this was ever documented in this patient.
The patient was a lot of years ago on anti-aggregant drugs, but she stopped because of the anemia, the starting of anemia. So the GP preferred to stop the anti-aggregants and to start the therapy with the iron by by us,
Oral,
so
oral
by
therapy, yes.
oral therapy, yes.
Which was very poorly tolerated, as you said.
Yes, because also the patient had an paroxystic atrial fibrillation. So and we can see that also at the moment of the entrance in the OR, in the ER, the patient was in rhythm, so she was not in atrial fibrillation. So the patient had only some episodes of atrial fibrillation.
And
so
answering Professor Collette's point about the excellent point about the angio CT scan, which is we always, of course, look for vascularization, and I think that was a very good point. I have to say that in my previous experience with emergency surgery in such situations, it's very difficult, even with an expert radiologist, to document a pneumatosis of the gastric wall. But I think it's a very good point, because we should raise awareness of this possibility, which is a clear indication for emergency surgery. I totally agree. Can we move ahead, Emanuele, please?
Yes. So we started the assessment in the multidisciplinary anesthesiology point of view. So we, as we know, we started with the ASA physical status classification that, as everybody of us know, is a limited system for assessing the fitness of patients before surgery, and it was established in 1963 by the American Society of Anesthesiologists. And this classification adopted 5 category physical status classification, and this patient was classified in the score system 3. Because this patient in this condition was not considered in an emergency status, but after placing the NG tube, after doing the first investigations, and after that, so we can consider to treat the patient in ordinary surgery. And after that, we also calculated the age-adjusted Charlson Comorbidity Index, that this particularly score system that indicates the estimated risk of 10 years survival rate, that for this patient was the points, the score for 5 pointers is quite high level, with a 21% or estimated 10-year survival rate. So was not so it was sick patient, but the risky for the surgery is considered quite high. So we started doing some complementary investigations, and we say before we performed a cardiopulmonary test. We do this test for some particular patients, and it's a test that it's useful to understand the cardiorespiratory endurance of the patient, and also it's important to clarify the level of fitness of the patient. And for this patient, she had a significant reduction of effort tolerance. The peak of VO2 was quite low, with a 54% of predicted O2 consumption, and the reduction of maximal ventilation with peak ventilatory equivalence 64 liters minute, that was about 52% of predicted one, so quite low. This is a very beautiful movie that is representing the presence of a mass, that is a stomach here, that is compressing the right chambers of the heart. And in this section, you can see that the stomach is completely empty. So you can imagine what happens after a large meal, when the stomach enlarges and compresses more and more the chambers of the heart. And This is a very interesting study. It was a case report that we have published some years ago, and is very interesting because in this case report we considered a 40-year-old man with a body mass index of 36 that was referred to our outpatient clinic with a 3-month history of postprandial fullness and resting dyspnea. And so we started to evaluate the impact of the stomach enlargement on the cardiac function with the use of cardiac magnetic resonance that was done with a typical machine with a 1.5 Tesla equipment, and was performed in the fasting condition that we can see in the picture A, where the stomach is empty, and after a standard meal. The standard meal that we gave to the patient was a meal that was done with included a bar with cereals and seeds and some liquid about 250 milliliters of liquid yogurt. And so this standard meal was able to enlarge the stomach, to stress the chambers of the heart. And we can see here it is after the post-operative evaluation of the patient that is showing disappearance of the hernia and the regular shape of the inferior vena cava that in the previous images was completely compressed by the mass of the stomach that was completely enlarged. So it was one of the first representation of this problem with a dynamic evaluation with the magnetic resonance. It was very, very interesting. So now I give
Thank you, Emanuele. I think you made a good point, but we'll come back later on the assessment of the cardiac function. Now, Stefano Siboni, are you connected?
Yes, here I am.
Among the complementary investigations, I think that the role of manometry can be very intriguing, and we listen to your data and experience.
Yes, thank you. Thank you very much, Professor Bonavina. Thank you, Professor Julie. So the reason why HRM has been proposed as a preoperative test for large hiatal hernia is the fear for achalasia. So basically is, achalasia, as you can see in the plot, in the screen, or other major disorders of the body of the esophagus. So in the plot here, you can see the typical type 2 achalasia, which is extremely rare in patients with large hiatal hernia. We did a lead search and we couldn't find anything but only 1 or 2 case reports. So what could happen in a more regular basis is this. So is the incomplete transition of the probe through the LES or the crura diaphragm. So you can have this wonderful butterfly image, but as a matter of fact, you can't really study in a complete way the LES and the complex between the LEX and the CD, the crura diaphragm. So this is another example.
Here just a second, Stefano.
Yes.
Just to clarify that in this patient, HRM was not performed. I mean,
Yes.
we are discussing the potential role, just for clarity.
Yeah, thank you. And what can happen in what we can view in a patient with a large hiatal hernia is this. So we have a very clear 2 peaks image. So we have the peak of the LES and the very small peak of the crura diaphragm, as you can see here in the monitor, and a huge distance between the 2 of them. And usually the peak of the crural diaphragm is very low because of the enlargement of the hiatus. I think one interesting point will be discussed about IAM, so ineffective esophageal motility. When sometimes we perform the HM in these patients, and we found ineffective esophageal motility. And there will be a lot of consideration about that. First of all, a recent article by our co-chairman Triafidopoulos very well demonstrated that ineffective motility is not consistent over time. So he demonstrated there could be a change about 20% of patients that were firstly diagnosed with ineffective motility that changed the diagnosis at the second manometry without any surgical operation. So we still have to figure out the real clinical significance of ineffective motility. And secondly, as far as I know, in the literature, the worst outcome of ineffective motility for surgical operation has not been demonstrated yet. And third of all, with the reconstruction that we plan for large hiatal hernia, which is a partial fundoplications, there should not be problem of dysphagia in the postoperative course. So we really don't fear this finding. If we don't change this test, doesn't change our current practice. So we decide now not to perform routinely. We perform high resolution manometry only if the patient has either severe dysphagia or dilation of the esophagus at the swallow study. So this is the end.
Yes, very good, Stefano. I think that your message probably went through very well. In real world practice, I'm sure that our colleagues will agree, there is no real room for doing an esophageal manometry. I'm curious to hear from George, which is his opinion, from the surgical standpoint, since, as we'll show you later, we do a crural repair and a partial 270-degree toupee fundoplication as a routine in those elderly patients with large hernias. We don't care much about the motility, also because as we learn from George, ineffective motility, you know, we have to be careful about definition of ineffective motility. The only problem could be to not to recognize an underlying achalasia. But we have seen only one patient with this problem. We were we successfully dilated him. We did a pneumatic dilation after the procedure, and he did well. And in the literature, there are very rare, I think there is only one case report published about the concomitant occurrence of achalasia and giant hiatus hernia. What do you think, George?
Well, I agree with the comments made and the recent comment that you made also. I do agree that the key element here is to rule out achalasia. I think that sometimes in the context like this patient, it's very difficult or almost impossible to take the probe through the esophagogastric junction. In many cases, actually, we manage to do that, but we do not see, other than esophagogastric junction outlet obstruction, we do not see any disturbed motility proximal to the esophagogastric junction. Of course, in this case, it will be almost impossible to do a motility. Ideally, what I would like to see is when you do the operation and the hernia repair, if you need to do basically a Heller myotomy at the same time, that would be great. But these days we have not only pneumatic dilation, but we also have POEM that we can do in the context of recognition of the achalasia after the operation. Frequently, in this case, we do see the esophagogastric junction outlet obstruction without any features in the body of the esophagus. And I think, as Dr. Simponi pointed out, by the way, thank you for reading my article. Probably you're the only one who read it. It's an easy thing to do is you look at the body, either radiographically or by manometry, and if you see some peristalsis, then you're probably home safe. And I don't think that's a difficult thing to do, even if you miss the opportunity to look down through the esophagogastric junction. So I think overall, I agree with you, Luigi, that it's not that critical other than excluding achalasia, which you probably can do.
George, I think we have Hiroshi Mashimo who'd like to intervene.
Yes, very good. Yeah, I was looking for him.
Well, thanks a lot. I'm sorry I'm juggling so badly here, but I do have a little bit of retrieve while my rant panel is going on. So a few comments I was making notes on, so believe me, despite being turned off on the video, I was listening. Comment on esophageal manometry. I would actually humbly say that there is a role for this. And literature, the game changer really has been in the high resolution, I believe. And the reason is this, that there are several papers that have come up since the high resolution. When you compare the endoscopy to the manometry, the sensitivity and specificity on some of these papers actually show that they're better. Now, I don't mean for someone this overt that anyone can tell that this thing is a blown out hiatal hernia. That said, the fallbacks are really in all these studies. How was the endoscopy done? And how was the manometry done? And my own opinion here is that we don't do the endoscopy correctly. We don't do it correctly because we're not patient. An endoscopist is very privileged to be able to put sufficient air in a retroflexed position so that they can actually blow out hiatal hernias. And when they're subtle, they're often missed. A radiologist, on the other hand, unless you definitely tell them to use, effervescence, etc., are not in a position to truly distend the stomach. So in a way, a subtle hiatal hernia can easily become a large one once you have a retroflex view of the stomach with ample insufflation. Granted that when you do that, you might even replicate some of the patient's symptoms if they're mildly sedated. That said, one of the hallmarks in this particular case, and what makes it so difficult, is that generally you don't get these kind of volvulus or organoaxial distortions unless there is a perisophageal herniation. That again is very badly missed by many endoscopists because one, they're not insufflating, or they're not in a position, particularly with propofol, to allow the patient to take a nasal sniff. Without that, you will often miss a diaphragmatic pinch and totally miss a large perisophageal hernia. So in that relevance, I would highly advocate that in subtle cases, not this overt, that in the retroflex position, when there are subtle herniations, to bring back the concept of a hill flap. The hill flap was a flap that would be totally effaced in these positions, in these conditions. So that I would advocate is something that we have to bring back, as well as advocate the need for a careful, totally insufflated, retroflexed endoscopy. So where does the manometry fit? I don't think that it's really in the mere issue of ruling out an achalasia, which obviously is very, very important. But I think that as a motility person, we often don't tell the key components to this. Granted that the hiatal hernia will not be exaggerated, unlike endoscopy, they're generally pretty good with the high resolution down to about 1.8 centimeter gap between the high pressure zone, which we define not as a high pressure zone, but because of the rebound contraction that you'll see in a non-achalasia. So you should see a rebound contraction. That's what's defining the actual lower esophageal sphincter. And we know this also because from animal studies that we've performed, in the deletion of the neuronal nitric oxide, that part is completely missing. So a little bit of a pro for motility guys out there, that the rebound contraction will help you localize the LES even when it's in a very aberrant position. So the gap between the high pressure zone that you're now identifying as the LES and the diaphragm or the diaphragmatic pitch may be totally obfuscated when the herniation is very large. So that is a caveat because we're trying to look for that on the manometry and it may totally be gone. Nevertheless, in a case like this, it's very easy because the distance is so different. One of the issues in terms of going back to this type 1 versus type 2 or mixed herniations is really that if a person has more an odynophagia component with the swallowing, it's really rare unless huge like this that actually come down with pain during the swallow. In fact, what is often missed is the paraesophageal hernia, particularly when they're small. So that's a caveat to have a truly careful retroflexed exam during this, that can aid the surgeons before the surgery.
Excellent points, Hiroshi. Thank you. Can we go next to the
Luigi?
Okay, yep. Yes, please.
May I ask a question to Siboni, but also to George, who is online?
Yes, of course.
Do you think, because the high resolution manometry in such a large hiatal hernia, which of course, as George emphasized, is also due to the stension, but anyway, 10 centimeter, it could be 7 or 6, but it's anyway a very large hiatal hernia. You don't need high resolution manometry to see the clear separation of the two sphincters. And also, by the way, to exclude achalasia, if I remember well in what you sent me, you did not a barium, but a gastrografin swallow, so you were able to exclude it. On the contrary, to study well the anatomy, either pre-operative and maybe even better post-operatively, the endoflip would be much better. So may I have the comments of George about the endoflip?
I don't really have personal experience with endoflip. In my center, Dr. Clark, who may or may not be here at this conference, does it. So I think endoflip in theory should be useful, but I personally do not do it. Dr. Clark is doing it. And so if he's around, maybe he can make a comment later on. So that's one thing. The other thing is that in terms of manometry with a high resolution probe, sometimes it's impossible to get through the esophagogastric junction. And I use the endoscope to carry the tube down through the esophagogastric junction in certain unusual circumstances. So I don't know, Dr. Simponi, do you have any comments?
Yes. I don't think that the endoflip may add something really useful in the preoperative assessment. Maybe it can be it can have a role in the intraoperative assessment. So if we insert the endoflip during the operation, we can see if about the motility, about the clearance of the esophagus, and maybe we can tailor the anti-reflux procedure on this patient based on the endoflip results.
There is some echo. It's a little disturbing. Can you?
Maybe you should
fix it?
telephone. The mobile
Yeah.
phone.
Oh,
Okay.
yeah, okay. Okay. Yeah, maybe so. Maybe you can add something in the intraoperative assessment. So we can tailor the anti-reflux surgery on the endoflip results during the operation. But I don't think that in the operative assessment, especially in the patient with the big esophagitis, with the grade B esophagitis, with the Cameron ulcer, I don't think this, I mean, it can be also dangerous for bleeding and not be useful in the assessment to program the operation, I guess.
Luigi, George, I think we have a comment from Dr. Viswanath.
Hi, good afternoon, everybody. It's from UK. Greetings from UK. Just a few comments and also reiterate colleagues and so forth. It's excellent discussion. From the point of dyspnea, and I think it's the combination due to cardiac, pulmonary, as well as diaphragmatic compression. And we have had patients in the last few years, patients with postprandial dyspnea, along with they say they turn blue. That means bit of cyanosis. Only the patients say, but you can't see it always. So certainly, in a previous case report by colleagues clearly exemplify the importance of compression of the vena cava as well as the atrial and chambers. Clearly telling us that the dyspnea component is not just one part of the cardiac or respiratory problems. From the point of manometry, I think, if you have got a structural problem, such as a big hiatus hernia with or without esophagitis, I don't think it's mandatory to do in every patient, but I can only see its importance to counsel the patient if they have got a lot of dysmotility, a lot of other esophageal problems as such. And so that you can say even after successful hiatal hernia operation, they may not notice huge improvement, for example, in dysphagia, if dysphagia is secondary to more dysmotile esophagus than due to the big hiatus hernia. And lastly, the endoscopy, I entirely agree, careful endoscopic assessment is so essential. But I would add one part, I hope the colleagues have done it in the past. Some patients, I do use image intensifier when I'm assessing this patient. You can take the J-Manual scope into the hiatus and look both on the X-ray screen as well as when you're doing that. Again, gives you a little bit more understanding about the location and complexity of the hiatus hernia. Yeah, that's me. Thank you.
Thank you. Very, very good points. I think we have John Clark waiting for, he should be with us. I just read the message. Yes, hi, John.
Hi. Just to comment upon Flip really quickly.
Sure.
I would agree that I think the pre-op assessment is relatively limited for Flip, but the one benefit that Flip has versus the HRM is that it is possible to guide it beyond the hernia much more easily. And so if you do have a large hernia with an angle, and it's challenging to get the manometry beyond that point, Flip is much easier to get beyond. The downside, though, is that what Flip is really looking at is secondary peristalsis, which is not the same as primary. So sometimes you can't directly extrapolate what the Flip will show towards HRM. But from a technical standpoint, it is a little bit more simple to get beyond the site.
Yes. Well, I think that the very good comment. I think that if we think in terms of real world practice, endoflip is also an expensive tool. And so we should, I think that for research purposes, both HRM and endoflip are great. They will expand our understanding of pathophysiology, but probably in patients who really need surgery to correct this mechanical problem, I think that we may just go, as George said before, a good radiological evaluation. You can see in the next, Emanuele should be ready to show you the Gastrografin swallow study that at least gives us confidence that the esophagus is not dilated and there is some emptying from the junction, so we can confidently operate on the patient. And you see here that the transit to the stomach is seems to be okay.
Yes.
Any comment, Emanuele?
Yes. After the complete obtaining the complete emptying of the stomach was the swallow study was done, and it represented a massive intrathoracic migration of the stomach with the organoaxial rotation, and as we can see here, the esophagus was not so dilated, but the outflow from the stomach was extremely slowed down. So after all, there was the transit through the pylorus, but extremely slowed down. For this examination, we used a Gastrografin. And after that, we were able to decide which was the best therapeutic option for this patient. Also, it was important to consider what was the willing of the patient and of the family that was very close to her. So the first choice was wait and see what happens versus palliation. What about placing feeding jejunostomy? What about placing, also in this patient was quite impossible to place a PEG because the stomach was completely in the chest. Or we can also perform a challenging cure with a gastropexy, with a fund application, placing a mesh, or just do the chloroplasty. What about esophageal lengthening for a patient like that? There is a brachysophagus. The short esophagus issue is always a big problem for the surgeon. So, which is, in your opinion, the best way to treat this patient to give the best quality of life?
Well, as you said, Emanuele, this is, of course, was discussed in our multidisciplinary board, taking also into account the magnetic resonance, etc. So it's a case-by-case decision. I think that nowadays we should proceed for cure whenever we have a patient like this, which is, of course, operable, and we should go ahead with that. The way we'll discuss a little later the wait and see approach. Can you go ahead and show our surgical management and plan and video?
Okay. Also, with the minimal invasive approach, was possible for this patient. The importance of this operation is nowadays lower. So it's important to perform the complete reduction of the hernia and the resection of the sac of the hernia. It's important to perform a posterior chloroplasty, and if it's necessary, also lateral chloroplasty and some detention incision of the diaphragm in order to reduce the tension during the chloroplasty. It's, in some cases, it's also important to place some augmentation of the resistance of the diaphragm with the mesh, like in order to buttress the resistance of the diaphragm. And as we have seen before, in patients like these, it's important to perform a partial fund application in order to avoid any sort of dysphagia, of post-operative dysphagia. This is the operation that was performed in in every cases in minimal invasive technique with a 5-port standard setup, And as you can see here, we started with the lysis of adhesions because of the open cholecystectomy and the artery resection. And you can see here that in this patient, the lysis of adhesion takes a lot of time, about 1.5 hours. And it's important to reduce with the gentle the stomach from the chest in order to avoid any damage of the stomach wall. You can see here that the stomach was pulled down in the abdomen. It was completely migrated in the chest, and we start here opening the pars flaccida of the lesser omentum, and then we started opening in the right pillar. It is our benchmark for the start this operation, and then we start with the mobilization of the part of that is around the stomach, and the dissection between the sac and the pleura, as you can see here on the right side here. Then in the close to the pericardium, it's sometimes happens that we open the pleura, but this is not a big problem, because it's important just to inform the anesthesiologist about that, and sometimes he needs to better adjust the PEEP and stuff like that in order to avoid any distress for the patient. And in this case, it's also important to avoid any damage of the esophagus that is sometimes completely covered by adhesions. It's important to use thermical energy with a lot of care. You can see here also it's important to perform blunt dissection. The esophagus was completely encircled with a Penrose drain. And then you can see that mobilization in the lower part of the chest was completed. It's important during this surgery to avoid, when it's possible, any damage of the posterior and anterior trunk of the vagus nerve. And okay. The excision of the hernia sac was then completed, as you can see here. Okay, you can see here the hernia sac that is divided in anterior part and then is removed. Sorry about that, it's crashed. Okay, we can see that the lengthening of the esophagus in the abdomen was very good. And we have to remember that we need to have about 3 centimeters of the esophagus stable in the abdomen before starting to repair the crura. We start preparing with the posterior cruroplasty with the intraoperative stitches in a non-absorbable stitch Prolene 2O. We placed we place the 3 stitches in the posterior part, and then we start to perform the lateral cruroplasty with 3 stitches, and then we continued in the operation of the crura again in the posterior part. It's important during the reparation to avoid any distortion in the position of the esophagus. And in this case, we decide to place a mesh. This mesh was an absorbable mesh, a long-lasting absorbable mesh, 7 centimeters wide and 11 centimeters in length, and was shaped in a U manner, just in the posterior part of the esophagus, and was fixed with 2 stitches. You can see here that it's important that the gastric fundus is completely freed up. And usually when we start to perform the posterior fundoplication, usually we don't place the bougie inside of the esophagus, but if we have any issue, any doubt about the strength of the plasty or the fundoplication, we perform an endoscopy, an intraoperative endoscopy. We can see here that we started in the left side for the construction of the fundoplication with the first stitch in Prolene, second stitch on the right side in Prolene 2, taking just a little bit of esophagus of the right pillar and then the gastric fundus. Then this is the third stitch and then the third one. After that, we complete the fundoplication, the first, the left, the right valve with a barbed suture, with a 3/0 barbed suture, in order to fashion the valve in the best way. In our experience, the mesh was never displaced from the crura. We were aware about that because we placed in the corner of the mesh four clips, titanium clips, that after the day after the surgery and the follow-up of the patient, we check the placement of the mesh that is in the regular place. And after that, the patient usually, like that usually stay in the ICU for overnight, and we perform a gastrografin as well study on postoperative day 1 or 2, and usually we discharge patient in postoperative day 3 or 4, start eating a soft diet. This is the gastrografin as well study in the postoperative day 2. You can see that is regular, there is no stricture, the stomach is in the regular position, and the passage through the pylorus of the gastrografin is complete. And this is also a magnetic resonance that was performed some months after in the follow-up of the patient. And as you can see here, there was the complete reduction of the stomach without any compression in the earth chambers and cave vein. So the patient performed follow-up after 3 months, performed a barium swallow study, cardiovascular dynamic MR, and after 6 months, an upper endoscopy and a cardiopulmonary assessment. Thank you.
Okay, thank you, Emanuele. I have a short video clip to follow this. Can you? To follow this, and because there is some innovation in surgery sometimes, to-pay fundoplication has stood the test of time as the Nissen fundoplication, but more recently we can share screen. Cosa devo fare? Ok, certo. Okay, just a second. Okay, this is another possibility of in some patients, selected patients, I would say, because this operation, which is the LINX procedure, was born as a procedure for uncomplicated gastroesophageal reflux procedure. But now indication have expanded, and you can see here the posterior vagus nerve, and this is the posterior wall of the esophagus. This is the hiatus. It has been dissected formally, and cruroplasty is performed, a cruroplasty without mesh. And through this we have gained those 3 centimeters, as Dr. Asti said before, of intra-abdominal esophagus. We measure the circumference of the esophagus and we apply a lynx. This can be a procedure for some selected patients as an alternative to the classical toupee fundoplication. Now, I would just I'm going now to conclude just reminding you that postprandial distress and anemia are the most typical symptoms in this disease, but also that 50% of those patients may be asymptomatic or oligosymptomatic. As a matter of fact, it is interesting now that there has been a paradigm shift over the past years. 2002, this famous paper published on Annals of Surgery was in favor of observation without surgery in patients with asymptomatic paraesophageal hernia. More recently, 2015, we have seen a significant reduction in morbidity and mortality associated with elective and also with emergency paraesophageal hernia repair. So we are at the point that elective laparoscopic repair should be weighed into treatment recommendations for those patients. Of course, this is not a recommendation based on, we don't have a strong level of recommendation based on the grade system, but from our experience, for example, we have seen that cardiovascular magnetic resonance with a challenge meal can be useful for selection of the best surgical candidates. And also, as Emanuele showed you before, the impaired global heart function can be reversible after laparoscopic fundoplication. So again, in very carefully selected patients, I think that surgical indication for laparoscopic surgery is very reasonable nowadays. Of course, make sure that you have a multidisciplinary assessment of those patients. Make sure that you have a clear, informed consent with the patient and the family, and then I think that we can undertake surgery without problems. Of course, we still have some problems with recurrent hernia. This is a very highly debated issue nowadays. So intraoperatively, we have to take into account the hiatal surface, the defect and shape of the defect, and we have to release tension, both radial tension and axial vector forces. And maybe we have to take care of esophageal shortening. So we can reduce radial tension. You see this big hiatus here. There is indeed a big radial tension. And sometimes we have some tricks to decrease radial tension and to make a good crural repair by decreasing the newborn peritoneum and by doing a left pleurotomy, some relaxing incisions. But I can tell you that in routine practice, we don't really use all those maneuvers, but we try to operate with a decreased pneumoperitoneum. We use a 9 millimeter of mercury intra-abdominal pressure. The other issue is that, as you saw before from Emanuele's presentation, we can add a mesh. We prefer a biosynthetic mesh. We don't like much the permanent mesh that can be dangerous. This is a mesh that can augment the resistance of the crura and is slowly reabsorbed within 1 year or so. So protect from recurrence during this period of time. The other problem is how to reduce axial tension. Usually we ask the anesthesiologist to increase PEEP. We, of course, do, as you said in the video that Emanuele showed you, an extended mediastinal dissection. This is a must for all those patients. We cannot make short of this. We need to do an extended mediastinal dissection. We need to resect all the hernia sac. Very occasionally, we may end up doing a Collis procedure, but this is a really rare event. I would say less than 5% of patients. And very, very extremely rare, it has been proposed that occasionally a truncal vagotomy should even be performed to try to elongate the esophagus. But again, this would represent, the Collis procedure represents, in our experience, less than 5% of the patient population. And this is how the Collis is performed. You see that we do a wedge resection of starting from the greater curvature, going to the esophagus, and then to the angle of ease. So we provide an elongation of at least 3 centimeters that makes us confident that we have we can do a toupet or even a Nissen fund application, but we have gained some length of intra-abdominal esophagus. Again, this is a rarely done procedure, and we don't think that this is the standard. The standard, as you saw, is a complete laparoscopic operation with reduction of the and the resection of the hernia sac, crural repair, and laparoscopic toupet fund application. I guess that we may have raised questions and comments and debate, but we are quite confident to propose this as the gold standard nowadays for this condition.
Luigi, I
George?
think we have a few
Yes.
comments and questions. I
Sure.
took it like this. I saw Italo. I think Roger
Yes.
was the first to raise questions, then Stefan, and then Italo.
Italo, Stefan?
Good afternoon.
So Roger first.
Thank you for the invitation and for the opportunity.
Hi, Italo.
Yes.
Hi, Italo. How are you?
Fine, you. My comment is concerning the moment, the opportunity to indicate the surgery for patients with huge hiatal hernia. I agree with you because nowadays, as you said, laparoscopic surgery offers very safe surgery without mortality and morbidity. But the problem for me is that the gastroenterologists, they don't send patients with hiatal hernia when they do the diagnosis. And patients like this patient wait more of 20 years for surgery. And then the patient arrives to surgery very old, very complicated, very bad performance status. And then and then I prefer to the diagnosis is done. This patient should be operated in 1998 when she has esophagitis and type 1 hiatal hernia, no waiting to have type 4 hiatal hernia. That is my comment, and please, my message is, please, the gastroenterology, they must to send to surgeon the patient when the diagnosis of hiatal hernia is did. And that was my comment.
Very good, Italo. I tend to agree with you, although I'm not sure that this patient really had such a huge hernia 20 years ago, because we really don't know about, we had some charts telling us the history, and we don't know who was the endoscopist doing the procedure 20 years ago. And I agree with you that we need to have a consensus with our friends, because gastroenterologists are indeed our friends. We have to cooperate with gastroenterologists, with ENT, with the pneumologists, and with the, we should work in a network of specialists and I'm sure that George will totally agree that to give a good quality of life when you are, over 80 years of age, although the life expectancy has improved so much recently, I think it's really too late. And as a matter of fact, it's my personal experience that patients tell us, well, should I have known the outcome of the operation, I would have come to you 10 years ago, maybe. And they realized that their quality of life had been so much impaired for a long, long time. And they were treated with just a PPI, just escalating the dose. And the patients with this condition, because this is not really a classic GERD, this is a different disease, because we have this is a disease of the diaphragm more than a disease of the sphincter, probably. So I think that the patients have the right to be treated on time. I need to get some answer also from George.
And maybe short answer, because we have a lot of people who'd like to comment and interview.
Very short answer. ESO is functioning in exactly that capacity. Brings together gastroenterologists and surgeons and other specialties together, so each other understands the other side and works together. At Stanford, we have a multidisciplinary clinic for all these patients, and we always share the patients and have a discussion. And I think that that will be advisable to everybody.
Great. Roger.
Well, thank you. I certainly agree with that. And I want to compliment you all on the great presentation and a lot of great points with which I agree. So I have two relatively quick questions. The first is you mentioned, Luigi, that that sometimes you'll use the magnetic sphincter augmentation with the links. And in that case, would you always try to do a manometry beforehand for those patients? I know we talked about that a little earlier about whether you do or do not for a paraesophageal hernia. And I'm not sure if that was only in the context of acute presentations.
Yeah.
And then my second question would be about the use of gastropexy sutures and whether or not your group ever does those. I found those helpful in some cases of larger hiatal hernias when there's a little bit more tension with the initial reduction or when you have a recurrent paraesophageal hernia. I'm just wondering what your thoughts are on those.
Thank you, Roger. I think, well, I show the links as a provocative video to show that it's feasible, it's possible. I would have never done links in an 82-year-old patient because still I'm confident with the toupee fundoplication, which in my at least in my experience, is a very good, very safe operation, virtually no side effects, no morbidity. So I think, of course, it takes a little longer to do a good toupee fundoplication because you have to be symmetric with the valves. You have to be very careful not to twist the esophagus, but still, I think is the ideal operation in an elderly patient with large hernia. Having said that, I think that I'm open to the links, but probably in younger patients, also because the opportunity to do an esophageal manometry, as we said before, is not so common, and because sometimes, I mean, the failure rate of passing the probe is quite high. So I don't think it's routinely feasible. And the second question was, can you remind me? Sorry.
Yes, concerning the use of Gastropexy sutures.
Yeah, well, Gastropexy, I agree. I don't think there is enough evidence to show that it should be done because there is no evidence, but it's quite easy to do. And I agree with you that in some circumstances, fix the anterior wall of the stomach, and this can relieve some pressure on the hiatus, even if we augment the hiatus repair. So I think it can be done. As you know, some people, some colleagues also do even a PEG in those patients, but I don't think it's a good way to go. I think that gastropexy is feasible, it's safe, and it can be done in selected patients.
I agree. I think a PEG is a poor choice.
Yep.
Stefan, I think you had a comment as well.
Yeah, Luigi, congratulations for the excellent video.
Hi, Stefan.
Yeah,
How are you?
I'm fine. I do it in the same way, only robotic. And I have two questions. Do you think it is always necessary to do a toupee? I do it, but in discussions with Paul Schneider and with others, they are doing now door in these voluminous hernias. This is the first question. And the second is the resorbable net mesh a good one, or is it necessary to have a non-resorbable mesh in these giant hernias? What do you think?
Well, I think that the robotic is very welcome. I do not have personal experience with that, but I think it's is a very good alternative. Maybe give you you have more freedom of movements inside. It's good. And regarding you mentioned the door fundoplication. Okay. Yes. So I think that well, I prefer the toupee because the toupee is a nice buttress on the posterior hiatus, and it I think in those patients where you mobilize a good part of the greater curvature, you can do a nicely anatomically better toupee than a door. And as you know, toupee is a better protection for reflux compared to the door. So I stick with the toupee fundoplication. Did I miss another question? Probably you asked me something else. No,
it was.
Oh yeah, the mesh. Well, we still use the biosynthetic mesh. Those that are commercially available are the BioA and the Phasix. We have recently implanted a number of this biosynthetic mesh, which is lasts a little longer compared to the BioA. But both are feasible and easily implantable. We don't have, I have to say, strong evidence from the literature that having a mesh works. I think that the basic of this operation is release of axial tension and having a good segment of intra-abdominal esophagus. Mesh can contribute to reduce recurrences and could contribute to have a less important recurrence. I mean a recurrence that you may not need to reoperate, and the patient does well without further treatment.
Okay.
Luigi, we had a comment from Dr. Viswanath as well.
Yes.
Hi, Luigi. Again, thank you for conducting this higher order discussion, and we're enjoying it. So from my side, if it's an elderly patient with comorbidity, I just do DOR, which is probably 5-10 minutes, 15 minutes lesser from the point of time and duration of the operation. But I agree that toupee from the point of reflux is good enough, as you said. What about the drains? I have had a couple of colleagues from Midlands and southern part of UK. They have had problems from the point of the mediastinal collections and early herniation. I started putting a drain into the sac or mediastinum and just take it out after 24-48 hours. So what's your view on that?
Yes, well, I think as we showed, the main trick is to get rid of the sac. Cutting the sac around the borders of the hiatus is a factor for recurrence. So we need to excise the sac completely, and then, yes, we leave a small Blake drain inside, and we leave that for 24 to 48 hours. And that's enough. We never had, bleeding problems like that over the past years.
Yeah, that's great.
Thank you. We had a last comment from Justin.
Yes.
Hi.
Hi, Justin.
A very interesting session. Thank you for the a chance to ask one or two questions. Basically, I think some of my colleagues have already asked them, but I'm just wondering, in the presence of gastric volvulus, I'm sure that must be quite challenging to do a fundoplication, with all the distorted anatomy. I'm just wondering, how actually do you handle that? And secondly is like, what would happen after this? I mean, what if there is a recurrent of the, say, hernia itself? Because, in such cases, there may be quite a high chance that it may come back again. Yeah, thank you.
Yes, good points. First of all, I think I can assure you that most of my colleagues and surgeons and friends, we don't care about the hernia or the stomach itself. Actually, we follow a plane, as Dr. Asti showed before, a plane which is between the pleura and the sac. So our main aim is to remove the sac. When you remove the sac of the hernia and you just traction down the sac, you reduce the stomach completely in the abdomen. And so I think that your concern about the anatomical difficulty is relative. I think that this is, of course, this is an operation that requires, as all operations, even in inguinal hernia, requires a learning curve, requires some expertise in advanced laparoscopic surgery, requires great and strict collaboration with your anesthesiologist, because there is a team of people that work on the patients. We, the surgeons, we do our job, but we have to talk to the anesthesiologist during the operation and to inform him about any problem, the accidental pleural opening or stuff like that. Everything is controllable by an expert anesthesiologist. So this is the reason why, as also Italo Braghetto and Roger said before, it's a real safe operation nowadays. We are really confident with that. And I probably miss another question from you. Pardon me, I don't remember.
Yeah, Luigi, I mean, the second one is about, you know, the recurrence.
Yes.
You know, what's next?
Okay. Well, you think what next in terms of surgical technique or innovations, or okay, let me say first, recurrence of a giant paraesophageal hernia or intrathoracic stomach, of course, is a problem, but the recurrence rate has decreased slowly over the past years with by improving surgical technique. I think that David Watson from Adelaide was one of the first, and Glyn Jameson, to show clearly that resection of the hernia sac is a key technical aspect of the operation. If you remove the hernia sac, the likelihood of having a recurrent hernia is lower. And the second point is that even you can get hernias occasionally in those patients when they come back to the follow-up clinic. You see an X-rays, you see a barium swallow showing that there is a, let's say, 2 to 3 centimeter herniation. Most of those patients, I can assure you, are asymptomatic. So the burden of a recurrence in most of those patients is not so high how you as a gastroenterologist can expect. I would be more positive, and of course we have to improve our technical skills, and maybe mesh augmentation is not perfect yet. We can improve on that, and maybe we have to discern in some cases that we can be more liberal in using a lengthening procedure such as the Colles, because this can make an advantage, but just for a small patient subgroup.
Right.
Luigi.
Thank you very much.
Luigi,
Yes.
this is Carmelo.
Yes,
Just
Carmelo.
a technical question. How much is the incidence of postoperative dysphagia with your toupee operation? And second, do you cut the small vessels?
Okay, very good question. Incidence of dysphagia is low with the toupee fundoplication. We counsel our patients before surgery that they have to learn how to eat again. Of course, this is very difficult to tell a patient who is 85 years old, maybe a dentulous, but they should follow a strict diet regimen in order to reduce the likelihood of having bolus obstruction. This is for sure. I can tell you what's happened after this operation in our series is between 5 to 10% of our patients, they can have a delayed gastric emptying, which can be due, in my opinion, to a paresis of the posterior vagus nerve. In patients who complain of this problem, we have we went back to the videos to see if, of course, we injured the vagus, but in most of those patients was a transient phenomenon, and so we recommend to do an endoscopy, we recommend to avoid salads, to avoid some food that can even worsen gastric emptying. And we do after a month or two. Sometimes we go and do a rigiflex balloon dilatation of the pylorus. But usually this is a transient phenomenon. So in other words, we see more patients with delayed gastric emptying than patients with postoperative dysphagia, indicating that toupee fundoplication does not produce mechanical obstruction as the Nissen can do.
Luigi, I suggest we take a last question from Vikash. Maybe short question, short answer, because we are lagging
over time.
Okay. Hi everybody. So I'm Vikash from South Africa. I think I've put some comments into the group chat. But my concerns were, for example, with patients having surgery, and I think it was echoed now that the lifestyle modifications, I think, needed to go hand in hand, both pre and post surgery in terms of patient management. I'm just thinking in the case of South Africa, where the pathway to care is probably different to many other regions of the world, where first-line therapy with PPIs and so forth would work. But we might miss the case where we need to then move on to second line of therapy when you're having a type 1 hernia. And I was just wondering whether the patient cohort that we're referring to, what characteristics do they have in terms of, for example, comorbidities, BMI, whether they're immunocompromised or whether they have other comorbid conditions like diabetes and so forth. Have there been, work done to show that these processes really improve the outcome in such patients? That was the first thing that I just wanted some elaboration on. The issue around the stents has been covered somewhat, but I was just concerned, in South Africa, they still, stents are quite expensive, and the issue around synthetic biologic stents. And I was wondering more about the complications that can arise, with stenting, like your esophageal erosion, strictures, dysphagia, and so forth, and whether that is a case that you see, because one has to cost for the repeated management in such cases. So perhaps I think, in the interest of time, those are just the two burning issues that we have. And I think certainly this has given a lot of insight in terms of, from a South African perspective, because this, we've been following the American and the European guidelines, but some sort of a local guideline would also help in terms of our patient pathway process. And then also an educational program in terms of helping our younger doctors understand the complexities around this, because most of our training comes through industry partners. But I think through OESO, we can certainly, help to sort of increase the level of competencies amongst our younger doctors going forward. So if those two questions can just be answered, I'd be happy. Thank you.
Yeah, well, I agree with the concepts you gave to us. And counseling, again, is very important. I think that for doing good anti-reflux surgery to be successful, the first thing is to convince the patient that he has to restart again after surgery. So he must be educated for that. This may be for Robert, for the OESO, a nice opportunity. And I'm sure that George will agree that we can elaborate maybe some common guidelines for global education for those patients who are candidates for anti-reflux surgery. I'm sure that a program like that can really improve quality of life and outcomes of surgery. In other words, the surgeon, again, is not the only actor. We as surgeons have the responsibility to take care of our patients together with our partners, gastroenterologists. I probably missed part of the questions where you mentioned about possibility of strictures and erosions. I guess you were alluding to the use of mesh. Am I right? Or
yes,
maybe?
yes, the use
Okay.
of mesh. That's
So
right.
I think that mesh, I think that we don't have a clear-cut evidence, but we can carefully use those biosynthetic mesh with some short, medium-term outcomes, but we do not have good trials to show the efficacy. There is a very famous American trial, multi-center. I think that Roger, was one of the co-authors of that study that showed that the really early absorbable mesh don't work at all. So we think that maybe we straddle in the middle between the totally absorbable and permanent mesh. We have those biosynthetic mesh that may help some patients. But again, we do not have strong evidence in support of this observation.
Thank you, Luigi. So I believe we need to close this session. Thank you all for being there. Maybe one word of conclusion, Luigi, then George, then Robert.
Yes. Well, my special thanks go first to you, Frederick, and for your way you coordinated and organized this session with a perfect rigor. And this is my first and special thanks I convey to you. The whole meeting has been recorded, I guess, as you told me, and he will figure among the assets of the OESO-SEMPIRE Platform of Excellence. And we had, I think, today a beautiful demonstration of the incredibly didactic way this discussion was driven, like a course of multidisciplinary course of gastroenterology. And my special recognition goes to Luigi Bonavina for the way he conducted the discussion and the presentation with his colleagues, and to all the panelists and the people here around us, I say here around us today, with a special recognition to George T. He is my close friend. He is the emblematic figure of the platform and of OESO, of which he is the president of honor. And his wise appraisal of situations and dynamic initiatives are some of the characteristics of his invaluable presence. And that is why the prospect of position papers that Luigi put forward at the end of this session today will certainly come to reality very easily with him, with George, and with all those in the various pilot centers that are included and on board with us. And finally, the 9 bullet points of the slide that I asked Frederick to show and to show here are better than any speech, to show what OESO stands in the scientific community. Organizational resilience since 1984, established independence across many disciplines, original concept, global reach on all continents, modern aspirations, ever-changing, inspirational to the young, a forum for friendship and novelty, interdisciplinary, breaking institutional barriers and silos, equal opportunity for career growth and networking, collaboration with industry and foundation partners, and the last one that I cherish, a family beyond family. And I thank all those that were today among the esophageal family to have contributed to the quality of the discussion and to the value of this new initiative. Thank you. to everybody.
I would like to invite everyone who participated in this to consider making a presentation from their own regions of the world and try to basically have a juxtaposition of their life in those parts of the world from what you heard today from Europe and the United States. Thank you, Luigi and team. Thank you, everybody, for participating.
Thank you, George. It was nice
you.
to have you. Bye-bye.
Bye.
Thank you. Bye. It was a privilege.
Bye.
Thank you. Thank you very much. Bye-bye.
Thank you. This was great.
Thank you.
Thank you.
Thank you.
Thank you,
Bye.
Robert. Bye.
Excellent job, guys.
Bye-bye. Nice to see you.
Bye-bye.
Bye next time.
Bye-bye. And thank you, Hiroshi. I know that you had a difficult time today, and thank you. You have finally been with us a short time, but an important time. Thank you.